So this topic is of major trauma and births, two topics that I'm very passionate about, and the slides aren't moving. Here we go. So essentially the focus of each is essentially to outline the major injuries in each major system from head to toe. So we'll focus on primary survey, secondary survey, neck, chest, abdomen, long bones, head, and all parts of the spine. And then in terms of the burns, the most important is resuscitation. The Parkland's formula, which keeps changing depending on what edition of ATLS you're using, how to assess a burn, when you transfer a burn, and how to manage it, and obviously the complications. So there are unfortunately a lot of words on these slides, which is not optimal, but this isn't one to make too interactive or case-based, but I will try my level best to make it case-based. So, or at least interactive. To make a case-based is a bit difficult. So just bear with me. So just some background information. I'm sure you guys know that major trauma is really the major leading, or one of the leading causes of mortality globally. And road traffic injuries on its own is the leading cause of death between the ages of 18 and 29. And more than 45 million yearly suffer from moderate to severe disability each year on its own because of trauma. And obviously the trauma ranges from mild, moderate, severe. Often people have a combination of both, and often multiple organ systems are involved. So the approach, and to have a systematic, structured approach, is the most important. And obviously that way we reduce the risk of missing things. So let me just move on to the next one. And then according to WHO, just in 2014 alone, deaths related to trauma were in the region of 1.25 million. And in 10 years from now, but I don't know with COVID at the moment, 10 years from now, taking COVID aside, trauma is supposed to be the third leading cause of death. Sorry, not of death, of disability. And penetrating injuries are responsible for less than 15% worldwide. That's worldwide. In South Africa, it's about 95% that's responsible for any traumatic related injuries are all penetrating, so gunshots and stab wounds. And patients with very severe trauma obviously have a very significant lower likelihood of mortality or morbidity if they are treated at a designated trauma center. So where I work, for example, here, it's what we call an MTC, which is a major trauma center. And we have something called the golden hour, which is the golden hour in which we rapidly intervene to get the best outcome. This often gets pushed to 4 hours because obviously if you've got major trauma and multi-systems involved, it's not all possible to do in 1 hour. So these little icons, I think I've changed the slides since I've sent them to you, and I do apologize for that, but I was just to try and make it a bit more interactive. So this is a favorite exam question. And if you remember pictures like I do instead of words, if you look at each little icon, it's essentially telling you the reasons of poor prognosis in major trauma, which essentially in life, in a medical exam, written or oral, is the same for everything. So it's always extremes of age, always pregnancy, always obesity, always anybody with multiple comorbidities. Obviously someone that's prolonged resuscitation or who is presented with arrest and needed CPR, long duration of CPR, a GCS that's low, major catastrophic hemorrhage, any organ that's failing or multiple organ failure, and the use of anticoagulation. So just to differentiate, it's so important for everything, your history, your clinical exam, your management, as well as the pathophysiology and you treating the patient to differentiate whether it's blunt or penetrating trauma. And in the interest of time, I'm just going to leave that on a second and not go through it. But essentially, you guys know penetrating is essentially gunshots or stabs. And we want to know things from the history, like what type of firearm was it? Was it a BB gun? Was it a kid's gun? Was it, you know, a proper pistol? Was it a rifle? Was it a blade? How deep did the blade penetrate? Is the patient still have the blade in? And actually that brings me to a question. If a patient comes in with a pole stuck in him or a blade stuck in him, What is the one thing you should not do? Feel free to type or speak because I can't see the box. So you've got a patient.
Don't pull it out.
Absolutely. Thank you so much. Why not?
Maybe increase the injury more severity. Bloods come out more.
You're going to increase the risk of sepsis and infection and major hemorrhage and cause more trauma as you're pulling this out, because you're not an X-ray person that can see, you know, it's not guided through radiology in which you're pulling it out. Also, the type of blade is important. Is it a Swiss knife? Is it a lot bigger knife? Is it a kitchen knife? And again, the intent is really important for documentation and legal purposes. Is it, you know, domestic violence? Is it a suicidal attempt? Or is it, you know, gang related? In terms of blunt, always look for the seatbelt use. You want the paramedics to always tell you the state of the car and the state of the other cars and the state of the people in the car and all the people around, and the state of the people in the other cars, because then that will tell you the damage that's been done. If they've been evacuated, you want to know the distance. If they've been extricated, they've got what we call a long lie. What do I mean by a long lie? So someone that's been extricated has been in the car or truck for quite a period of time, which means they have significant more hypoxemia and hypoxia. So they've got more injuries that have been left untreated for a longer amount of time. So that's probably another reason for a poor prognosis. And the biggest thing with them is you want to watch out for renal failure and rhabdomyolysis. What's rhabdomyolysis?
Break of the myocytes. Break off.
And what does that cause to your kidney?
What?
What does that cause in your kidney besides
acute tubular necrosis?
You guys are making me smile. Yes, acute tubular necrosis. So when those things happen, what are you going to look for in the urine?
Myoglobin?
Absolutely. So the urine is classically Coke colored, and you want to know the input-output. So what is the ideal output for a trauma patient, urine output? So for an adult, it's 1 milligram per kilo per hour is optimal resuscitation. If you're not getting that, they are under resuscitated. And for a child, anyone guessing? So it's just half that.
0.5?
Absolutely, 100%. So it's half that in a child. And lastly, fall from a height, you want to know, is it 1 meter? Is it 3 meters? Is it 6 feet? You know, whatever the distance is. And most importantly, what body part they've landed on, which has just made me think, if you've got to fall off a building, say 23 stories high, what are the two most injured parts? So yes, your brain's going to be injured, but there's two significant injuries with the fall from a height. Does anyone know what they are?
Lower limb and neck.
Close, not quite neck.
Spleen. Spleen.
Spleen is less common. What comes after neck?
The spinal cord.
So absolutely. So thoracic and lumbar first in fall from a height, although very much neck can be, but the ones that cause very poor prognosis are the ones that are missed T and L spine, and also lower limbs, absolutely. Do you know what they normally get? They normally get bilateral fractures. What fractures do they get?
We've got pelvis on the chat.
Further down. That's often missed because everybody's focusing on the big injuries, but it hurts like hell.
Maybe.
I think I heard someone say.
Hip fracture.
What fracture?
Hip fracture.
Hip fracture, yes. So pelvis, go further down, below the knees, go further down.
Yes.
Head of femur.
Further down.
Tibia.
Further down. What fracture of the foot? I think I heard someone say it's calcaneus fractures.
Calcaneus.
Yeah, bilateral calcaneus fractures in 90% of patients that fall from a height. And the reason I'm mentioning it is because they're often neurovascular compromise and you need to immobilize immediately. So often you've got multiple people in the room and you will tell somebody as team leader, can somebody put bilateral plaster casts on their lower limbs, because they often have tibia, femur, fibula, all of it, but those ones may not be displaced or compromised, whereas for some reason the calcaneus, because of the pressure and the axial loading, this goes crush, crush, and the calcaneus, both sides normally is the first to go. In terms of pre-alert, I think I touched on this last time. Does anybody remember what the sample history is? So we answer the phone to get a pre-alert, and it's the ambulance phoning. You often, it's not necessarily said in this order, but it's essentially all the necessary information you need. And again, a famous exam question is, so S is signs and symptoms, A is allergies, M is medication, P is previous medical and surgical history, L is last meal, and E is events leading up to the incident. Why is last meal important? Obviously, if it's known, if the patient is unconscious, we don't know what time they last ate. So if they're unconscious, say again.
Operation?
I didn't hear you.
For operation? For operation?
What part of the operation? Why is it worrying if I've eaten in 1 hour ago or if I've eaten 7 hours ago?
On the chat, there's aspiration risk.
Anesthesia, for anesthesia.
Anesthetic complications and aspiration. So the first thing you want to do is you want to deflate the stomach by inserting. What do you put in on them? What goes through the nose into the stomach?
Nasogastric tube.
Nasogastric tube.
Nasogastric tube. Fantastic, guys. I'm really impressed. You guys are interacting and getting all the questions right. So while somebody has answered that, you as a trauma team leader have put out what we call a trauma call. And you want to get everybody ready, right? So you've got all your disciplines. If it's a pregnant patient, you need to get obstetrics, gynecology, and neonatology. Just waiting for the ambulance to go past. Obviously orthopedics, you want radiology, you want interventional radiology, and obviously all your ED staff. Often this will happen at 3 o'clock in the morning. This is when you phone the person at home and you ask them to come in now, all right? You do not be afraid to call for help, because you are really going to struggle without help. You want to give ultrasound, which is often not available after hours, a heads up. And obviously you want to give theater a ring upstairs, and it's often multiple theaters that will need opening. And I say that because normally there's already a theater that's opening with your elective cesareans or whatever, as well as CT, because they're going to get a pan CT. What do I mean when I say pan CT?
For all of the body?
100%, so head to toe. Yeah, perfect. You want to get ready for all your procedures that you may anticipate. So intubating, your chest drains, your needle thoracostomies. You want to activate major hemorrhage protocol and then get one of the nurses to prepare the Belmont. What is the Belmont? Belmont is a device that gives blood really, really, really rapidly. So you've got multiple big lines in this patient. You may even have an interosseous line. And I've forgotten what the actual amount, seconds or minutes is, but I mean, it's a rapid amount of volume that you can infuse really, really quickly and safely. And it is a nightmare to set up. So you'll probably need 2 nurses to do it, because despite doing trauma for 8 years, I have no idea how to set up a Belmont, and I will mess it up. So mechanism of injury, we've just spoken about, like I said, fall from height, and you guys are absolutely right. We've discussed this. Just things to remember with being entrapped in a car. Their breathing is a problem, and they're often very difficult intubations, especially if they've been intubated on scene, because if they've been trapped in the car, the way the paramedics intubate will be through the roof. So they will enter the car through the roof and intubate the patient while the patient is sitting upright from the front. If any of you watch Grey's Anatomy, it is very interesting, and that is not how it's done, but that's probably 1% of what it really is. So you guys can look that up. It's quite gory. It's a lot of fun if you like the adrenaline and the blood, and it's extremely difficult. So you want someone experienced and someone who can do difficult airways, because you need to keep their spine not their spine, their C-spine completely immobilized. So you've got one person in the back seat holding their C-spine and someone like me in the front, then intubating from the front. And it's really a difficult airway. Sometimes because there's so much blood and vomit in the mouth, you can't intubate from the front and you go through the nose. Can anyone tell me when you go through the nose, in what patients you intubate through the nose immediately? You don't go through the mouth.
Any breakage in the mouth,
Any?
in the maxilla.
Absolutely. So
there is edema in the neck.
Beautiful.
We cannot open his mouth.
Absolutely. And in children and babies. So often you go straight, because those, especially babies, if there's a baby in the car, babies are nasal breathers. So you need to intubate. Their nose is the problem. So once you fix that, then they can breathe. And obviously you've got your spleen, kidney, and hemo and pneumo. So mechanism of injury is extremely important. You need to know things like, were the airbags deployed? Was the windshield damaged? Especially if the windshield is damaged, there's broken glass everywhere. So you've got foreign body. So what do you want to give them when they come to the emergency room? Two things. So sepsis, so antibiotics immediately, broad spectrum, your sepsis bundle. So you give 3, you take 3, and you want to make sure they have their tetanus injection early. Often these patients need tetanus immunoglobulin because they have severely infected wounds. And then head-on collision, as you can see, it's broken down. You've got different parts of the body that are injured. You want to know if the car was a head-on, was it a lateral, was it T-boned, was it just a back, and obviously how many miles or kilometers per hour they were, you expect them or suspect them to have been going. So essentially, this is your A to E assessment, A, B, C, D, E, remembering airway, breathing, circulation, disability, exposure, and environment. Remember, with airway comes C-spine protection, and with exposure comes environmental access, meaning you expose them head to toe, but you need a bear hugger or one of those silver blankets to keep them, the space blankets to keep them warm, because they are at huge risk of hypothermia. Also remember, with D, don't forget glucose. D is for disability, and don't forget glucose, because these patients will have sugars of 0, which will suppress the level of consciousness. You think you've intubated the patient and you've still got a poor response and no one has checked the sugar. Okay, so that's one of the first things that's correctable and reversible. And according to new ATLS guidelines, these are essentially the life-threatening injuries that you want to pick up in your primary survey. Again, if you look at the emoticons, not the emoticons, the icons, sorry. So you've got your lung, picture tracheobronchial tree, your lungs again, your heart for tamponade, massive hemothorax, obviously a reminder that they're going to need blood. And if you've got a traumatic cardiac arrest, then this may lead to front room thoracotomy, for which A, you need personnel that are qualified. B, you need to make sure there's clear indications, because normally if you're going to front room thoracotomy, so far in my experience of having done in excess of about 200 in South Africa, I've had about 1 or 2 that survive, and they survive for a couple of hours and then they're gone. It is mentally, emotionally, and physically exhausting, because you have never seen that amount of blood and it literally looks like a bloodbath. So again, you want your most experienced person in the room to do that. And luckily in Oxford, I've not needed to do one at all. We almost needed to do one a couple of weeks ago, but sadly the patient died before we even got to it. Also, the preparation for front room thoracotomy is a nightmare, because you just need to have everything ready. And it's not something you normally plan for, so it's a lot of chaos. So we've spoken a lot about this. I'm just going to go through it very quickly. So airway, the way you know airway is okay is it's obviously if they're talking to you, then airway is fine. You want to look at face, neck, chest, abdo. You know how to assess for difficulty of respiration. We went through this last time. Quick things you can do is insert an OPA or an NPA. Just remember, when do you not put in an NPA? Your nasopharyngeal airway. Does anyone remember?
Basal skull fracture.
Beautiful. base of skull fracture, or if you have an isolated cribriform plate injury. So another famous exam question will be 2 reasons to not put in an NPA. And just remember how you measure them, normally along the side. You guys can look that up. We've spoken about blood, vomit, pooling. So most important is to suction. And currently with COVID, suction counts as an aerosol generating procedure. So you will be in full level 2 PPE. Remember, you palpate the neck on all sides, not just midline tenderness, because you want to check for, what am I feeling for? Surgical emphysema or crepitus. Okay, that tells you, what does that tell you in the neck? What injury are you suspecting?
Rupture?
Injury?
Absolutely, as well as a pneumomediastinum, okay, or a widened mediastinum. So that's airway. This very quickly, how you assess the airway prior to intubation. There is a mnemonic called LEMON. L is for look externally, E is 332, which is essentially 3, why am I doing this wrong? You've got your 3 fingers between your mouth, then you've got your 3 fingers between the mandible and the hyoid bone, and then your 2 fingers from the hyoid to the thyroid. Just look that up. I think I may have done that wrong in doing this very quickly. Your Mallampati score, obviously the higher your score, the more difficult your airway. So you then want an ENT or an anesthetist around. O is for any sort of obstruction, your vomit, your blood, your secretions, and obviously obesity. The other thing is you want to have a razor because they'll have beards, which then messes everything up. And obviously neck mobility. Can they do this and this, which most of them can't because they're in C-spine immobilization. So this is just a list of things you want to have prepared. We've spoken about these already. The other things that you want to have prepared are your BVM, your bag valve mask attached to high flow oxygen, which again, high flow oxygen is an aerosol generating procedure. So level 2 with COVID. You want to have your rescue airways like your LMA. Remember, they need to be inflated and deflated to check that they're working before you use it. The thing that I absolutely love is the bougie, which helps you intubate. And you need someone to be the airway assistant, so you need to allocate roles beforehand. Again, very rarely, I've not done one in Oxford where we needed to do front of neck, but I've done a few in South Africa where you need to intubate because you're just not winning. Different sizes of ET tubes. What is the golden rule for ET tube sizes? Man, woman, sort of globalized or random average size?
The man, 9 centimeter, the woman 7.
So
centimeter.
7.5 normally. So 7.5 for a man and 7 for a woman. And when you're getting your kit ready, anybody know how many sizes you should have? What the range is? So normally you should just have 1 up and 1 down. So if you've estimated it's a size 7, you want to have a size 6 and a size 8. So 1 up and 1 down right next to you in case you need to adjust. Same with the blades. Most people are a Mach 3 or 4. You want to keep a 2 and a 5 in case you need to change. Please, please, please check that the laryngoscope is working. Open it and check that the light is working, because there's nothing worse than you realizing there's no battery and you're inside the patient's mouth, because then you're causing hypoxia. Right, so indications to intubate, favorite exam question. So obviously if somebody needs support of oxygenation and ventilation, if the airway needs protection, what GCS needs protection? A GCS of less than what equals intubation?
8.
Absolutely. So if you want to prevent airway obstruction, so someone that's GCS 9 or 10, and you can see rapidly they've dropped from 15 and they keep dropping, you're not going to wait for them to become GCS 8. If they need global analgesia, head to toe, it's just easier because you want to prevent raised intracranial pressure. And in terms of sedation as well, you want to then put them into what we call a medically induced coma to allow for safe transfer, often it's for district hospital to a major trauma center. And then something called neuroprotective measures, which the main element is permissive hypotension. And essentially what you do with your CO2 management. We've got fixed targets. I'm not going to go into that. That's quite a difficult concept. But the main thing is if you just answer neuroprotective measures, that's all you need to know for now. Main thing of front of neck access, you've got your indications, your contraindications. And again, you bleed. It's just a bloodbath. Often it's a failed procedure, and it's traumatic even for the doctors in the room. You've got your acute complications that obviously happen immediately, as well as your late. And again, if you're doing this, you've got at least 10 people in the room that can help you. You'll have a person that's going to be your first attempt, second attempt, and then decide, is it worth doing a third attempt, or do you call it? You've got your equipment here on the side. This used to be a favorite exam question as well, the complications of early and late needle and surgical crikes, as well as the contraindications. And remember, this is all operator dependent. If you're not comfortable, you don't want to go in and damage structures. What's the most common structure that gets damaged?
Epiglottis.
Before that, that's a little bit later on.
Larynx.
Vocal cords, absolutely.
Esophagus.
Esophagus is also slightly later on. Your vocal cords, what nerve gets injured? What causes hoarseness?
Recurrent laryngeal.
Laryngeal.
Nerve.
Absolutely, recurrent laryngeal. So again, famous exam question. This is also one of your life-threatening complications that you want to avoid and recognize early. So it's essentially any form of respiratory compromise. We've spoken about the crepitus, where you suggest, or that's suggestive of a fracture, where you've got pneumomediastinum, a pneumothorax that despite 2 thoracostomies and thoracotomies, so you put your what do you call these things? You'll put your intercostal drains in bilaterally and they're still not getting better, or there's still no air entry, they're still desaturating. Then you think, am I missing a tracheobronchial tree injury? Which if you are, there's nothing more you can do in the A&E. They need to go to surgery, and they've probably had penetrating trauma. And these are the 3 most injured areas. So in terms of the esophageal lacerations, it's normally deeper lacerations. So normally with a surgical crike. So just read the question or the scenario. You get different early and late complications depending on needle or surgical crike. So this is just showing you what a pneumomediastinum looks like. And all this here is surgical emphysema, or what that looks like, as well as here in the corner. As you can see, it's missing on this side. Same thing here. This is the nasogastric tube. What's wrong with the nasogastric tube here?
Not in the stomach, outside the stomach.
It's in the thorax, right? So this needs to come out immediately, because it's then a foreign body gone into or an already compromised space. So in terms of breathing and ventilation, another famous exam question is, there used to be, I think it used to be something with an A, I can't even remember, but it's just the new mnemonic is Tomcat. So these are the ones you want to recognize. So tension pneumo, open pneumo, massive hemo, cardiac tamponade, and then we've spoken about the tree injuries. That's what you want to look for. So who can tell me, I mean, it's on the screen, but still, what is the difference between an open, closed, and tension pneumothorax, and what's the most worrying one?
Tension pneumothorax is the most worrying one because it's like a valve, so it keeps the air getting in but not getting out.
Absolutely. So you've got a buildup of negative intrathoracic pressure. The quick one to fix, where you're just going to literally see, tension is a quick one to fix, but that's slightly more difficult in that it's a more complicated one. But your open pneumothorax is when you can literally just put a dressing on, and it must have a 3-way seal. That's your most important. Closed pneumothorax, what's your classic patient that presents with a closed pneumothorax?
Tall and thin and young.
Tall, male. 2 more things.
Thin.
Tall and
Thin and smoker, right? So tall, thin, smoker is your classic closed pneumothorax. And do you know when in a closed pneumothorax you put in a chest drain? What size do you put in a chest drain? So if the pneumothorax is more than 2 centimeters, if there is airway compromise, and if they have low saturation, which is obviously airway compromise. Pain is not an indication to put in an intercostal drain. So for pain, what are the things you can do for somebody with a closed pneumothorax? So you can offer them a rib block or patient-controlled analgesia. So that's obviously not something you're going to do. You're going to get cardiothoracics or the anesthetist to come help you with that. Because remember, an intercostal drain is great, but it has its own complications and it hurts like hell. So this is showing you a pneumothorax. You can see this is a huge one. So this clearly would need a drain. As well as the side, you can see the trachea has been deviated. Can you all see that? This is actually not as clear as I thought it would be. But essentially with a pneumothorax, you've got tracheal deviation to the other side. So in terms of circulation, I'm not going to go through the major hemorrhage protocol again, but just remember, favorite exam question, what it entails. So it's your 4 units of FFPs, 2 cryoprecipitate, and 1 pool of platelets. And just remember, you're obviously going to give universal blood until the cross-match blood comes back. And most patients here in the UK already get TXA, which is your tranexamic acid, on scene. So when they come to the ED, then they need tranexamic acid over 8 hours to obviously continue. And then most patients have really messed up coagulation. So you need to reverse that either with vitamin K or your prothrombin complex concentrate, which is your PCC. Remember, with bleeding, you need to stop the bleeding and control the bleeding. So if you think of it as a tap, the bleeding is going to keep going until you close the tap. So you need to get to the source. So yes, you're giving them blood, but if they've got a pelvic fracture where you bleed to death or a femur fracture, they need to control that bleeding. So 2 things that you can do to stop bleeding with a pelvic fracture. What can you do? Or 1 thing rather. Pelvic fracture, you've given them blood.
Pelvic band.
Absolutely. That is so, so, so important. You see the patient's blood pressure is still on the floor and you're giving them blood and you think, oh, they're missing a pelvic binder. So you rather put one on, and here you'd rather do more than do less. Okay, same with the femur fracture. How do you stop a femur fracture from bleeding?
Put a tourniquet.
Tourniquet? No. I think I heard you say it. What was that?
A tourniquet?
Tourniquet in femoral artery.
That's going to be someone that's very specialized, and it's probably going to be lower down on your priority list, even quicker than that a nurse could do for you. Also starting with the T, where you immobilize with traction, right? So you can put traction on, which will stop the bleeding and also reduce the pain. And just remember, your cross match is very important. So you give universal blood until you can give cross-match blood specific to the patient's blood type. Remember, again, favorite exam question, how is sorry, love, go on.
How traction will stop the bleeding from the femur fracture?
Because it aligns the bones in place. So then there's no open space, you're reducing the space. So remember, you've got bone on bone. Normally in a fracture, it's normally completely 100% displaced in major trauma. By traction, you're doing this. So the space, instead of it being like this, has probably now decreased from like this to about this. Can you see my hands?
Yeah.
Yeah. So you're decreasing
the
bleeding.
But what if we have bleeding from artery? Is the traction will benefit?
Bleeding from artery, so that will be definitive surgical intervention, absolutely. But I mean, to stabilize as best as you can in the emergency room prior to transfer to theater. 100% right. If you've got bleeding from the artery, they need surgery. That's the definitive. But I'm just talking of buying time, because I guarantee you that the orthopod or the vascular surgeon is not going to be on site. He or she will be coming from home. So in that time, when you've got an hour to stabilize, you want to stabilize everything that you can. So just remember Beck's triad. I think we did this last time. Your classic, what makes up the triad is muffled heart sounds, elevated JVP, and a low blood pressure. And remember, they often ask how you differentiate a pericardial effusion from a tension pneumothorax. Both have elevated JVP, both have hypertension, but your tension pneumothorax will have a deviated trachea that's missing from the slide, and obviously no breath sounds. Massive, massive hemothorax here. This is all blood. So what do you want to insert here?
Chest tube.
Chest tube.
Beautiful. What is your location or your anatomy for that?
Axillary line. The fourth.
So
Fourth and fifth.
Intercostal line, fourth or fifth space, mid-axillary line. Here you can even go mid-clavicular line. Always remember, you've got other reasons for shock that are not caused by bleeding. So if the patient has had an MI prior to driving, had an MI, collapsed, then had the car accident, or patient who's got a pacemaker that stopped working, has then had a car accident, patient that's been swallowing aspirin like it's chocolate for backache, has had a major GI bleed, collapsed, then had the accident. So always just think of other things. Someone worse off than me right now who's had really bad news and is then behind the car, not paying attention, missed a red light. So think of your other factors that can cause shock, okay? And just remember, shock is not just a low BP. There's an absolute definition of shock, essentially causing hypoxia and multi-organ dysfunction. So in terms of D, disability is essentially your brain. You want to protect your brain. So check for any focal neurology, check for raised intracranial pressure. What is Brown-Séquard syndrome? So that is hemisection of the cord. I'm not going to go into it, but it's essentially when your spinal cord splits in half, you get ipsilateral, meaning on the same side, and contralateral signs. So you've got motor loss and pain and temperature loss, but on opposite sides. So you guys can look up about that. I'm not going to go into it. It's quite a difficult one. Essentially, these patients have very, very, very poor prognosis. I've seen one in my life, majorly paralyzed, and it's not something nice to see. Pupils, obviously, you want to check their size, their reactivity. You also want to check your AVPU score, because often it's difficult. If a patient is intubated, then you can't work out V, right? So as in your GCS is eyes, motor, and verbal. If they're verbal, if they're intubated, you can't assess verbal at all. Then you'd switch to your AVP.
I think also it's caused hemiparaplegia.
Absolutely, it does. Yeah. Well done. It really does. So there's a few. There's also a central cord syndrome. Does anyone know what that is?
Anterior.
Anterior cord, central cord syndrome. Anterior cord. So central cord is where
syndrome.
Yeah.
Syringomyelia, the central cord.
Not quite syringomyalgia. So central cord is when you've got weakness post-trauma, where the upper limbs are more weak than the lower limbs. And it's normally with C-spine injuries. And then you've got your anterior cord and your syringomyalgia. Those are your 4 spinal cord ones that you need to know. But that's quite a complex one, so I didn't go into it for now. But well done. I'm impressed that you guys know that. Then in terms of E, so E for me, you can do under exposure, sorry, glucose for me, you can do under exposure or under D. As I said, for D for me is don't forget the glucose. Remember temperature control, and you need to literally expose the patient from head to toe. These are what we call another famous exam question. They'll say, list all the areas we miss injuries, and it's all those tiny areas you wouldn't normally think of. So the scalp, behind the ears, obese patients, they've just got fat that it's rolled up. You need to look, because those things, you've got bleeding areas, and they've got scar tissue, adipose tissue, the perineum. You want to do a PR when you log roll them, and the gluteal areas as well. So diagnostic tests, obviously x-rays, we've talked about the different findings. Fast scan for those that are qualified to do it. Essentially, these patients are going to need a pan-CT. Are you going to delay the pan-CT to do a fast? No, because if they're unstable, they're going to need a pan-CT, but you need to stabilize them prior. So if you've got 10 people around the patient, one person is qualified, great, do your fast. An extended fast, anybody know the difference between the two?
Yes, this is
Say again.
echo, extended.
Absolutely. So the extended
I
fast.
think extended fast is with echo.
So it'll include the heart. So it'll have your 4 chambers of the heart and not just the pericardial effusion. Your ECG obviously will tell you about arrhythmias. Also, if they've had a massive MI. Also, it could show you Q waves, meaning they've had a previous MI and there's residual damage. Laboratory studies. Go on, guys. Besides your cross match, what bloods do you need? What bloods are you going to send to the lab? So FBC, what else?
In the case of
Sorry?
Serum lights.
Absolutely. So full blood count, urea, electrolytes, what else? How are you going to check if they have bleeding dysfunction?
in the case of pericardial effusion, pericardial effusion, we can use e-fast.
Yeah, you can, absolutely. So, but no, that's still part of your normal fast. The e-fast will be for other cardiac events.
Yeah.
So your pericardial effusion is your subxiphoid view when you're looking towards the shoulder. That'll tell you if there's a pericardial effusion. So your lab is your FBC, your urea and electrolytes, liver function, coagulation, obviously a cross match. Those are your standard trauma bloods. And we spoke about it earlier, rhabdomyolysis. There's a blood test you can check for.
Blood cells, platelets.
Absolutely. So that'll be on your FBC. But specifically for rhabdomyolysis or crush injury, what blood test can you check for?
CPK.
Beautiful. So you want to send off a CK as well. So in terms of secondary evaluation, head to toe, I've spoken majority about these. You just want to make sure you don't miss other injuries. So we've spoken about esophageal perf. Your fractures, main thing you want to check in your fractures that they don't have compartment syndrome. What is the treatment for compartment syndrome? The definitive treatment?
Incision.
Absolutely. Incision, fasciotomy. Just careful with saying the word incision in an exam, because then you're not telling the examiner you know, although I know what you mean. Use the word fasciotomy to get your marks. You might only get half points for fasciotomy, sorry, for incision. Absolutely. So fasciotomy, and then don't forget the pancreas and the duodenum. You can also get a ruptured diaphragm. And again, urethral injuries, when to not put in a catheter. What is the main reason to not put in a catheter in a trauma patient? If you've got blood at the urethra.
Bloody urethra?
Absolutely, right? So if you've got frank hematuria, you need to think, oh, something is wrong. Physical examination, head to toe, we've spoken about most of these things. Just remember, early antibiotics, tetanus, give 3, take 3, your sepsis bundle, serial blood gases, check your lactate. If they've got a massively distended abdomen and it's not fat, there is blood in that abdomen. All right, so surgeons, they need to be around. And the other thing for catheter contraindication is a high riding prostate, which till today I have never seen. So I have no idea what it looks like other than in a textbook. Beware of nasal hematomas. What will this cause a problem with? So say with me, I've got a blocked nose, pretend it's blocked with trauma. If I've got a blocked nose like this and I'm unconscious, what have I compromised?
Airway.
Absolutely. So nasal hematoma, they cause septal deformities, pool of blood. So your airway is compromised. Pitfalls and pearls. Just remember, if you've intubated and they're not getting better, have you actually intubated the right part of the anatomy? Is it an esophageal intubation? Have you gone straight into the bronchus? Just remember that hemorrhagic shock, before you even pick it up, meaning before the blood pressure drops, you need to have lost 30% of your blood volume, which is a lot of blood before the blood pressure drops. So you're seeing someone with major trauma and a low blood pressure, they have already lost 30% of their blood volume, right? So that's major red flag. Beck's triad we've spoken about, which in reality, I have never ever seen. I've always picked it up on the fast, or just clinically, I've had a high suspicion for it. Bowel injuries, I'd see it a lot in Cape Town, where they would come in with stabs and they've got bowel sticking out. Two things to not do. You've got a stab knife, do not take out that stab, the knife. And you've got massive bowel evisceration. You've got a huge ton of bowel here. What can you do? Two things.
Cover it with wet.
Beautiful. Why? Why do you want to cover it?
To prevent it from necrosis.
From absolutely beautiful answer. To prevent from ischemia and necrosis. The other thing you can try and do is pack it back into the abdomen, depending on how big your wound is. You're not going to make the wound bigger to put back the bowel, but just in case it's a massive wound. And lastly, your open book pelvic fracture, your pelvic binder. Okay, don't forget that. Last things, we've spoken about compartment syndrome. Just remember, pregnant patients, you want to get a CTG monitor on them because you want to you want to monitor the fetal heart rate, and you want to turn the patient to their left lateral side because you're displacing the IVC. What is the best way to save mom in a major trauma in a major trauma accident that's pregnant? Say she's bleeding profusely. What's the best way to save mom?
Termination.
Absolutely. So termination would be delivering that baby regardless of how far along she is. You save mum, you have a chance of saving the baby. There is no way you're going to be able to save both, very rarely anyway. So even to save the baby, that baby needs to come out, and you're going to save the mom's life by getting that baby out. So we do what we call a perimortem cesarean section. The word mortem is in there because probably about 1 to 2% of those babies survive unless they full term. But then even then, the babies themselves have got major traumatic injuries. Elderly patients, be very, very careful with them. They do not mount the normal responses that young, healthy people would, like you and I. They've got major differences to their physiology and anatomy. And don't forget your ocular injuries. Remember your base of skull fractures. You've got battle sign, raccoon eyes. You'll have your swelling, your ecchymosis. You'll often have globe rupture and even subconjunctival hemorrhage. Most important thing in these patients, even if they have low GCS, analgesia and sedation, what is one way of knowing a patient is suffering from pain if they are intubated? What will tell you on their monitor? Or it could be a clue.
They will have high blood
Hypertension.
And before that?
Tachypneic.
Before that? Tachypneic won't tell you they're in pain. Tachypneic will tell you there's a breathing problem. What vital sign will be your
heart rate?
Absolutely. Tachycardia. A persistent persistent tachycardia often is pain related in the intubated patient, and sepsis. All right. So are they covered with antibiotics? There's a whole host of options you can use. Why have I put question mark next to morphine? What is the danger with morphine?
Respiratory arrest.
Absolutely. Respiratory depression, and it can also cause raised intracranial pressure in major trauma. So you want to stay away from it or give it in very, 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 very small increments by an absolute expert. My go-to is fentanyl and ketamine, and I'll add in benzo to relax them as well. And these patients don't need bolus. They don't need stat, meaning once off. They'll need continuous bolus infusions. So that is something extremely important. And they often have a separate team altogether, a pain management team, in addition to all their other treatments. And where are these patients going to be? Which ward in the hospital? What's the most critical ward that you have in the hospital?
ICU.
Okay, so strict infection measures. So burns. How do I get rid of my chat box? Okay, how do you tell the difference between a superficial burn and a partial thickness burn? Essentially, a superficial burn is what you get from being in the sun. If you're as brown as me, you don't get sunburnt a little bit, you get sunburnt a lot. And when I get sunburnt, then my skin goes blacker than my hair, which is very black naturally. So it's obviously easier to spot on Caucasian skin. Just remember, I've got a picture of a baby here. Why have I got the picture of the baby here? What am I trying to illustrate?
Abuse, maybe?
Abuse.
Yeah. So non-accidental injury, right? Because babies shouldn't be burning themselves. So that's a big, big, big red flag. They often don't have blisters. They are very painful. The less painful the burn is, the more serious and dangerous it is because it's a deeper burn. And obviously superficial burns are dry, they're red, they blanch with pressure. So this is what I mean. I mean, when you touch them, they blanch. And normally by the 4th day, they start healing already. So in terms of partial thickness, before, in my day, it used to be 1st degree, 2nd degree, 3rd degree, 4th degree. It's not, it's not that anymore. It's now superficial or partial, and then partial gets broken down into essentially whether the epidermis is involved or the dermis is involved. And if the dermis is involved, then how much of the dermis is involved. So essentially these are the more worrying ones, and then you get superficial partial and deep partial. This is also a very famous exam question, the classification of burns, because as I said, in my day, it used to be 1st degree, 2nd degree, etc. So superficial ones, the most important is that they cause scarring. They take about 3 weeks to heal, whereas the deep ones take a little bit over 2 months to heal. They can or cannot have joint dysfunction, and you've often seen patients with severe burns that have joint dysfunction. What's the word I'm looking for? What do they often have for life as a result of a burn or because of really bad scarring? It's a specific word.
Strictures?
Contractures. You're close.
Oh,
so they have strictures as well, and they have contractures, okay? And the deep ones are painful to pressure, and obviously they extend deeper into the dermis. And it's often if a face is involved, most people have very little fat on their skin and there's little bone. So it goes straight down. Sorry, not there's little bone, there's little fat and the bone is quite up. So it goes straight from the dermis deeper down into the bone. Unlike on a thigh where you've got significant adipose tissue before bone penetration. Obviously the superficial partial thickness ones, they blanch still. They are painful, they are red, and they're weeping. And again, weeping, what do you want to give them? Weeping means infected. Infection means you want to give them?
Antibiotics.
Absolutely. And with antibiotics and an infection, they also need tetanus. Okay, so burns, just remember antibiotics and tetanus. Here's a quick question. Can you ever give somebody too much tetanus? If you ask me when I've last had my tetanus injection, and I honestly don't know, I'm a terrible doctor patient that way. What if I stand on a rusty nail? Are you going to give me a tetanus, or are you going to say, you're a doctor, you've probably had your immunizations?
No, it's better to give it to you rather than...
Right, so you can never have too much of tetanus. You can't overdose on it. So if you're an idiot like me and you don't remember your vaccination status, rather just give it to the patient, especially if it's a child, okay? And remember, it's in a court of law, you're doing more good than harm, so you're absolutely protected. So on the left is a picture of a superficial partial thickness burn, and on the right is a deep partial thickness burn. I almost said to you guys, don't worry, I don't have COVID. And then I just remembered you're on the other side of the world, but I promise this is not COVID related. This is what a full thickness burn looks like. Often the uglier a burn looks, it will tell you the thickness. This again, as you can see, is the blistering. This is the whiteness that I'm talking about. This is what we call desquamation, okay? These burns very quickly complicate into a life-threatening condition. What condition am I talking about?
Shock?
Necrosis?
Necrotizing fasciitis, which leads to shock. Beautiful, right?
Yeah, sepsis on the chat as well.
Sepsis, severe sepsis. And then they get Eschar formation. And again, how do you treat a buildup of pressure? If you've got pressure buildup, you've got compartment syndrome, fasciotomy, and hydration. 100% correct. If you don't answer with hydration, you'd get half the mark, right? So just read your questions carefully, or however if it's either written or an oral exam. Your mechanisms of burn, you've got different aspects. So heat, electrical, friction, chemical, radiation. You can just read the different explanations. It's pretty obvious. Chemical would be an actual chemical. Radiation would be, you know, for example, ionizing radiation through a severe sunburn, if they've got heat stroke. Thermal, obviously linked to the cold. Electrical is if you've touched like barbed wire. I'm just going to move on. So size of burns, you've all heard of the rule of nines, yes? Or should I go into it? Whoops, sorry. Have you heard of the rule of nines?
Yeah.
Yeah, so something to just remember. And again, unfortunately, back in my day, there was no apps, but now there's apps, so you don't really need to remember it. But in the exam situation, you do need to remember it. So essentially 4.5, 1% around the perineum, 4.5, 4.5, 4.5, 4.5. So anterior, posterior, and then 9, if you divide it in half, 9, and then legs are 9, 9. And then you obviously add each part up that's burned. The easier way, for me at least, because I can't remember those, sadly, you just use your palm. And in pediatric, it's just this part, which is half. And in adults, essentially, it's your whole, the circle, they've changed it now, is 0.8%. So if you can do that kind of maths, so each area that you touch, if it circles the palm, in an adult, it's 0.8%. Whereas in a child, your whole hand is 1%, or if it's just the palm, then it's 0.5%. That's what this picture on the right is trying to explain. But like I said, until you need to learn it for exams, use the apps, because there's tons of apps, and normally it's MD Calculator that I like to use. This keeps changing. Back in the day, it used to be 2 mils times body surface area times weight in kilograms, which is obviously the Parkland's formula, and you give the first half over 8 hours and the second half over 16 hours. This is rapidly changing to be 3 mils, which is rapidly changing to be 2 mils. So when you guys are studying, just look at your textbooks or whatever you've been taught in class and use that. But if you're doing an oral, you can say and sound cool by saying it's rapidly changing, and it's and according to which edition you're following of ATLS, it's between 2 to 4, and obviously in a child, it's going to be the lower amount. Management, pain management is the most important after releasing their buildup of pressure with an Eschar. Sorry, that's what I meant to say. In burns, it's not a fasciotomy. Fasciotomy is for compartment syndrome. The word in burns is Escharotomy. I made the same mistake, so bad question on me. You want to obviously prevent any VTE, so any venous thromboembolism. You want to check their coagulation status, antibiotics. They have very poor nutrition and have a high risk of becoming malnourished, even healthy people. So you want to make sure that is addressed. And just remember the psychological aspects. You're treating the patient as a whole. So try and remember mind, body, soul, and think of your triad as holistically treating the patient. It's often difficult for me to remember because my bandwidth is about 10 or 15 minutes. I see you, I stabilize you, and then you're an inpatient problem. But often these burns are really, really bad in terms of their scarring, and they leave horrible scars. So early plastics involvement, and just speak to the patient and apologize to the patient. Because, I mean, even the men, I've seen some horrific burns, and especially if it's a face or neck or a young patient, I mean, it's deeply, deeply traumatic. And you'll be surprised, that's the thing they're worried about. They're less worried about their abnormal blood gas. So your indications, this is exactly what it looks like. I'm sorry it's so gory. I tried to not put in too many gory pictures when you do an Escharotomy. And again, very skilled people do this because you can cause a lot of damage if it's done wrong. They can often present, again, with signs of compartment syndrome, which will be your absent pulses or neurovascular compromise, as well as new neurology. And then just remember, again, there's only 3, but remember for everything, age, extreme of age. This should also say extreme of age and not just 60. So essentially elderly people, although my mom would kill me if I said anyone over 60 was elderly, but in terms of burns, anyone above 60 has a poor prognosis. Remember, burns of total surface area more than 40% are huge problems, as well as inhalation injuries. This is a classic exam question. Does anybody want to give me 2 or 3 signs of inhalation injury burns? So they're
black of the nasal mucosa.
Beautiful, yep. So more signs of carbon monoxide poisoning. Let me just open the chat. I see it's going. So more signs of inhalation burns. So basically facial involvement, right? But you're absolutely, I see the chat, burns of the hair in the nose, laryngeal edema, facial burns, airway compromise, hoarse voice, nasal soot, carbonaceous sputum. Those are all signs. And obviously entrapped in a room with a fire. So they get severe carbon monoxide poisoning, which they'll have massive abnormalities on their blood. And the treatment for carbon monoxide poisoning, the mainstay of treatment, anyone?
100 oxygen.
Absolutely. So 100% high flow oxygen. And again, high flow in the COVID time, and I keep stressing this because after having had COVID, you need to please, when you're in contact, wear your level 2 PPE for anything that's aerosol generating. Okay, this is another very common question, transferred to burn center. So clear indications, one of them is an inhalation injury, any electrical burn, any chemical burn, your special burns, which are basically face, hand, genitalia, or your major joints, non-accidental injury, any full thickness burn or a partial thickness burn more than 10%. Anybody know what intima is? Intima is a mnemonic that got me through med school. So when you are asked in an exam, the causes or the complications or a differential diagnosis to anything in life, in medicine, and I can't remember, I use the mnemonic intima because that gives me the answers that I'm looking for. So intima, I is infection or inflammatory, N is neoplastic, T is trauma and toxins, and in South Africa, tuberculosis. I is iatrogenic, M is metabolic, and A is autoimmune. Also in South Africa, I with infection, you need to think of HIV. So if you're ever confused as to causes of something, you use intima and you can work it out. And when you, it's simple things like metabolic causes, most things will either cause hypo or hyper electrolyte imbalance. So hyper or hypoglycemia, hyponatremia, hypo or hyperkalemia. Lots of things are related to autoimmune. Everything in South Africa is TB associated something or HIV associated something. Neoplasm accounts for all your malignancies. You get trauma-induced complications, toxin-induced. And remember, toxin is not just an overdose. It could be medication toxin like digoxin toxicity. You could have a snake bite, a scorpion bite, and inflammatory conditions. So it's just something to remember. So the reason I put that up is because the next slide is, I've just explained this, the next slide is complications of burns. So even if you were unsure, if you went using intima, you would get at least 50% of the marks. So essentially every system is involved and you have failure of each of the systems. Just remember with renal failure, we've spoken about this, you first get rhabdomyolysis or you get crush injury, rhabdomyolysis, ATN, which is your acute tubular necrosis, and I've just forgotten, and then you get renal failure. Okay, so you've got stages of that, and you want to obviously prevent the end stage, which is renal failure. So we've spoken about sepsis, the need for antibiotics, the need for tetanus, major fluid resuscitation. Just remember in the elderly, they may have underlying cardiac failure, so you want to weigh out how much fluid you're going to give them. They are not easy to ventilate because their pressures in their lungs are really, really difficult to adjust. So again, you're going to need respiratory support and a specialist. So you often need the pleural or the respiratory team on top of the ICU team. Their livers are very prone to injury, as well as their GIT and their gut mucosa. So, which is why nutrition is very important. And a lot of them will need TPN, total parenteral nutrition, meaning they'll get IV nutrition, because if they're intubated, they're not going to be eating. So you need dietitians to be involved. They often have raised intracranial pressure, which you want to try and reduce. And the answer to that would be your neuroprotective measures. Just very quickly, just remember I said the words permissive hypotension. And the other thing is just slight elevation of the bed. Over the years, it's changed. When I was a med student 10 years ago, it used to be 45 degrees. It's now 30 degrees. And like I said, the most important thing is you get GI failure as well. And they are very, very prone to seizures. So they often get prophylaxis anti-epileptics to prevent, because you're not going to know an intubated patient who's in a medically induced coma if they're fitting, because you've taken away that by giving them medication to keep them sedated. That's actually a good question. How do you know an intubated patient that is heavily sedated is having a seizure? Because they're not going to be shaking like a normal person. I've given them too many drugs. So what would be your clue?
EEG?
Absolutely, beautiful answer. Say again.
Got heart rate.
Vital signs?
Vital signs, beautiful. What vitals? I heard somebody say it already.
Heart rate?
Beautiful.
Increase in heart rate?
The eyes.
What about the eyes?
Blinking of eyes or what?
So they remember the eyes will probably close, but often the eyes will be twitching.
Mm-hmm.
So that is your seizure activity.
There's a suggestion of the tongue being involved.
Absolutely. That was my next question. You can get tongue fasciculations, but normally you can't see them because you've got a tube. But somebody close enough may be able to. So the nurse that's nursing may be able to see that. Beautiful. What have I left out? Yeah, I've spoken about the rest on the slide. Excuse me. Again, just remember risk factors. And again, if you're confused, think of the pictures from the first slide with all the icons. Pregnancy, anyone that's required any sort of delayed procedure, meaning delayed extrication, delayed resuscitation, over-resuscitated, under-resuscitated, temperatures that are too high or too low, someone that's had massive blood loss, someone whose platelets are on the floor. There is a saying, I think I told you guys last time, blood on the floor. Can anyone finish it? If you blood on the floor.
And 4 more.
Beautiful. What does that mean? So blood on the floor and 4 more, which means there are 4 other areas that you need to look for that are most likely bleeding. Can't remember the percentage, but if I remember correctly, it's 90%. Don't quote me on that. I need to double check that. The last thing I want to leave you with is this, because I think it's very pertinent in the COVID area. In the COVID era, in that I really, really believe America and UK are literally months away from having a major event that could eventually become something we treat like mass casualty. Because essentially, if the rates just keep going up and up, which they do, it's going to become, the last time we've had something like this was the bubonic plague. So it's going to become mass casualty and survival of the fittest. And always remember, it's life over limb. So what I mean by that is the way patients get saved, and this is now I'm going back to major trauma, and I was just linking it to what's happening in the world today. If you've got a broken leg and your blood pressure is on the floor and you are 80 years old approximately, and I've got a 9-year-old next to me who's just got a broken, deformed wrist, I'm obviously going to focus on that 9-year-old, right? Because it's survival of the fittest. This is in mass casualty or major incident. So just to highlight, the handover from the pre-hospital people is different in this scenario when you've got a major incident. And have you guys heard of the mnemonic methane? So methane is the mnemonic of what the handover will be. It's no longer sample, and it's no longer SBAR. SBAR is also another mnemonic to use, which is situation, background, assessment and recommendation, and that's normally the mnemonic you use to refer patients to an inpatient team. So methane is major incident has been declared. So say, for example, the president or the prime minister or CDC or WHO has declared a major incident. Or if I'm just thinking of, say there's a major bomb scare, or actually the bomb has exploded, or say 9/11. So major incident is declared, exact location of the incident, exact location of where he or she is phoning from, type of incident, hazards present and hazards suspected or expected, access routes that are saved, because just think of it, with 9/11, most of the routes were closed. And I mean, even airspace with all the fire and the smoke, the helicopters couldn't reach the patients. Number, type, and severity, these are all guesstimate. And I use guesstimate because you're guessing the estimate. Okay, it's a very important word in medicine, which is you're guessing the estimate as opposed to estimating. And the last one is emergency services present on scene and what is still required. Okay, and again, the last thing I want to leave you with is the first thing I started with. All these things, we are amazing people and we all think we aren't ever not okay. And just remember, everything you do has an element of PTSD, and the older you become and the more advanced and the more senior you become, these things have an impact on you. And it can be something small that sets you off. It could be something big, and you could have a delayed reaction to grief or to stress. So just remember that it's okay to not be okay. And again, if that's the only thing you take away from this teaching today, then I'll be happy knowing that. Thank you for your time. I think this is the last. Yes, it is. Thank you for your time. Thank you for coming. It means a lot to me that you guys have come. And yeah, I have some time for a few questions. So takeaway points from patients. Let me just read this again. What are some takeaway points about patient psychology? I'm not sure I understand the question. Do you mean how do you handle it if a patient is feeling down? Is that what your question is? So I think the fact that you can recognize it is really a win for the patient. And it's simple things that would give away the patient is not okay, or there's a psych element to it, in that they won't maintain eye contact. They could pretend to have a cold. I mean, I was honest about it, and be crying the entire time, or have a blocked nose, you know, from having cried the whole day. Their eyes could be red, sacs under their eyes. They're closed off with their posture. So I think just noticing those things and then being aware and adjusting your tone. I'm sure if you compare my tone in this lecture to the last one, now that you know what I previously sound like, you could probably hear an element of sadness maybe. And often patients, while telling you something, they will change their tone. So those are other key things to recognize, and just recognize it and ask them how you can help. So there's something that we were taught that's called ICE, which is ideas, concerns, and expectations. So it's not really applicable in the A&E setting, but again, the older I get, the more I appreciate that. So I ask them, what do you think? What are your ideas of what's going on today? What are your concerns? And what do you expect from me today? And how can I meet that expectation? This is also great when you've got a screaming patient who's upset because they are upset because they've waited 4 hours and somebody else waited 2 minutes, but they were bleeding to death. So you can then understand where they're coming from, and often just talking down to them, apologizing to them for their pain, because there's no way you can take away the pain like this, and acknowledging it. And often say, you know what, I feel your pain. I've lost someone in a major car accident, or I'm having a difficult day myself too. So I know what it feels like. And if you don't know what it feels like, say, I can only imagine what it feels like, and I'm here for you. You're in a safe place. These are pamphlets that I can refer you on to. We can admit you for safety. I can get the social worker involved. Who do you have at home that's supporting you? And then you can do a quick sad person score, which is your signs basically to ascertain how depressed a person is. And sad person, you get a score for each element, which is another mnemonic. So S is sex, age, and I've just forgotten, is it males or females that are at higher risk? I can't remember, I've gone blank. But if again, there's an MD calculator for this. Age, D is basically, I think, previous depression, previous depressive episode, No, that's P. P will be previous psychological history. E is, I can't actually remember what sad person, and I should know this. Hang on, let me just double check. Or if somebody, Liasha, do you mind just looking it up and typing it in while I continue speaking? Get a score for each of those categories, and then a score of, I think, more than 5 means inpatient admission. And that way you safety netted yourself that the patient is safe to go home. So that way you can at least engage with them. And I think the most important thing is to just be human, because sometimes you're irritated, and this will always be at 3 in the morning. I'm irritated and I've got a really irritated patient. I want to sleep. I haven't peed. I haven't had my coffee again. And then I'm sorry for the wait. Hi, I'm Natasha. And you'll just see sometimes, majority of the times, they immediately change because they realize that you appreciate how long they're waiting, even if it's for something stupid. It's essentially just the small things. And I think the other thing I say to my patients in terms of psych is celebrate the small victories. And I think in 2020 has been a year of plenty, lots of disaster, and I think more downs than ups. And I just tell people that, you know what, you're still standing. Maybe you're barely standing and you're hanging by a thread, but you're here, and I think you're doing the best. And it's often something like that from a stranger to a patient that makes the most difference. So it's the little things. And I think that's what I've learned over the years. And celebrate the small victories with you and your patients. And just remember your coping mechanisms. And then the same coping mechanisms for the patients. Tell them the same things I've told you. I think that's it. Did I answer your question? Thank you so much, guys.